Hi, and welcome to my talk on managing cough and swallowing or swallowing disorders, also known as dysphagia. My name is Michelle Ciucci, and I'm at the University of Wisconsin-Madison. So here on the left-hand side, we have a modified barium swallow study, a moving x-ray of a newly diagnosed patient with Parkinson's disease swallowing a barium bolus. And as you can see on this video, the swallowing is crisp and all the bolus gets down into the esophagus. Compare that with this same kind of study on the right. This is an individual with late-stage Parkinson's disease. You can already see that the bolus is in the aerodigestive pathway. It's starting to get into the airway. There's a lot of residue left over in the mouth, and now it has gotten into the patient's lungs, putting them at risk for aspiration pneumonia. So the question is, what happens during disease progression to cause widespread dysfunction in swallowing? First, let's just think about classical Parkinson's disease pathology. And the way we think about it is aggregated proteins like alpha-synuclein forming Lewy bodies and dopamine depletion in the brain, specifically nigrostriatal regions. And that will account for the classic signs of Parkinson's disease, such as tremor, bradykinesia, postural instability. But there's so much more that happens with Parkinson's disease. And we now know that pathology happens in almost all systems in the brain and body. And so, because swallowing is controlled by multiple brain centers and then peripheral nerves and muscles, and then involves the enteric nervous system, it's really no surprise that across time, when you have multiple systems affected by Parkinson's disease, you're going to end up with a complicated swallowing problem. This is a really nice review talking about some things that appear in the prodromal, early motor, and early stage versus late stage disease. If you notice here, this is when you have nigrostriatal dopamine depletion and you have a diagnosis. But well before that, you have earlier signs of dysfunction. Two of them that I care very much about as a speech pathologist is hypophonia, which is a quiet voice, and dysphagia, which is disordered swallowing. Now, in the earlier stages, dysphagia might not be very severe, but it will progress, and it's an important thing to know about as a patient and also as a healthcare provider. When we think about Parkinsonian dysphagia from the multiple studies that we've done across the years, basically, we summarize it as difficulty with preparing the bolus, what you're going to swallow, and then also clearing it. There's also reduced sensation, and this results in residue, which is leftover food or liquid. Airway compromise, meaning things are going down the wrong pipe. Impaired ability to cough and clear. So that's a really important part of Parkinson's disease that I'll talk a little bit about later, because if things are going down the wrong way, one thing we might be able to do is have the patient cough or clear a little bit better. Swallowing becomes very inefficient, and eventually people might be unable to meet nutrition and hydration needs by mouth. The morbidity and mortality associated with dysphagia is weight loss, changes in diet, meaning not being able to eat or drink the things that you want to, aspiration pneumonia, hospitalization as a result of this, and aspiration pneumonia is the leading cause of death related to Parkinson's disease. So what predicts who gets dysphagia and when? There's been a handful of studies, and basically the two main things that we know about now that age matters. So as you naturally age, swallowing does become different and sometimes dysfunctional. So the older you are, you might be more likely to already have some issues with swallowing. And then also disease severity. So we know that almost all people in the later stages of the disease have dysphagia. That's not to say, though, that this doesn't occur very early or even in the prodromal stages. One study recently looked at a patient's ability to cough voluntarily, so how strong that coughing was, their reflexive cough in response to inhaling capsaicin. And then if you add that with disease duration, you could predict that patients actually have a swallowing dysfunction. But the important question is, how are we measuring disease severity? Oftentimes we measure that by looking at the limb and other measures, and sometimes somebody might have pretty mild disease in the limb and have a lot of other problems and have a more significant dysphagia. being aware that dysphagia will happen is key to management. There's a huge role for education. And so everybody's on the same page about pathology that is widespread and complex. It occurs in the peripheral and central nervous system and many areas of the brain that control things like swallowing and speech. That there are other non-classical tremor, bradykinesia signs and symptoms, and dysphagia is one to look out. And that we should operate under the assumption that when somebody is diagnosed, dysphagia is already present. It might not be significantly functionally limiting the person at that point, but there probably are differences and it will progress. We always advocate for movement disorder specialists, and we want our movement disorder specialists to have education with regard to dysphagia and dysarthria, and also to pass on that education to patients and caregivers, and then also refer to the appropriate specialist, which is a speech pathologist. And I'll talk about that on the next slide. And then I think there's a huge role for outreach to our own professionals and our patients about swallowing disorders and how to evaluate, treat, prevent, and live better with Parkinson's disease. So our motto is evaluate early and often, and then a speech language pathologist or speech therapists or speech language therapists, SLTs, in other countries besides the US, we have a whole battery of tools that we use. One that's really helpful is a patient-reported outcome. Sometimes when they're asked specific questions with regard to swallowing, they might come up with the fact that, yeah, there are some things happening. Same thing with asking the caregiver. And then we have clinical swallowing evaluations that involve a physical exam, cranial nerve exam, trials with food. And then we have instrumented evaluation. One of them is the moving x-ray that I showed you at the beginning of this presentation, but we have other tricks up our sleeves as well. It's also important to remember that surgical and pharmacologic treatments can interfere with swallowing. So in terms of deep brain stimulation, the literature shows that there's really mixed effects. It seems to be related somewhat to high versus low frequency stimulation or the place of stimulation in the brain. And then same thing with levodopa, there's typically mixed effects. You have to remember that eating and swallowing does involve getting the food or liquid to the mouth, swallowing it down, recognizing food, endurance, fine motor control, gross motor control. So we're not surprised that these general treatments cause mixed effects, but the consensus really is that deep brain stimulation and levodopa do not improve swallowing to any appreciable degree. And the implications for this is that we need to look at each patient on a case-by-case basis and then adjust DBS settings or medications as needed. We have general treatment approaches that are appropriate, and we need to use the exam findings to implement them. So there's not just something that we do when somebody's diagnosed. We need to get data from an instrumented examination. So we have standard tools that help compensate for altered physiology. So we might ask somebody to tuck their chin or to swallow more forcefully. We might recommend some diet changes. And then we have some treatments that have a strong evidence base so far. One of them is expiratory muscle strength training. This has been empirically shown in randomized trials to improve cough, voluntary and reflexive cough, and swallow safety. But this does require maintenance. There's a handheld device. And this is something that we as a speech pathologist can teach the patients to do at home. And now there's promising evidence about specifically training cough as well. And so if you're interested in that, there are 3 researchers, Drs. Hegland and Brandymore out of the University of Florida and Dr. Ciucci out of Columbia University. Remember, please, Parkinson's disease and associated dysphagia are moving targets. So among patients, we have different phenotypes, medications, treatments that they're on, and we have an umbrella of Parkinsonism that isn't necessarily idiopathic Parkinson's disease. And then within a patient, we have age of onset, time with diagnosis, progression and severity, access to healthcare, treatments that they might be getting that might be interfering with swallowing, and motivation. So I like to take a proactive approach in managing dysphagia, and that includes knowing that Parkinson's disease is a whole body disease, but unfortunately we don't know the pathology underlying dysphagia. And that's something that we are working on. The onset and progression of dysphagia is relatively unknown, but we can be prepared upon diagnosis. Being an expert and an advocate is paramount to treatment. Parkinson's disease is a moving target requiring constant vigilance. That basic translational and clinical science are the keys to improving health and quality of life. So stay tuned for that. Thank you so much for inviting me to talk here. Thank you for your attention, and I hope that everybody is well.